Welcome to this explainer. Today, we're rigorously mapping the high-stakes, granular physiologic decision boundaries of trauma and surgery, and we're tackling this from a strict peer-to-peer perspective. No generic filler today. Instead, we're jumping straight into the complex decision boundaries where those really subtle variables completely shift your management in the trauma bay and the ICU. To systemize these exact surgical parameters, we've divided our clinical triage board into 4 algorithmic modules: blunt abdominal trauma resuscitation forks, penetrating trauma immediate operative indicators, post-operative fever chronology, and finally, clinical reconciliation and TROD variants.
All right, Module 1, ATLS, blunt abdominal trauma, and hemodynamic resuscitation forks. Let's trace the physiologic cascade of hemorrhagic shock and map out those solid organ injury mechanics.
So the entire Advanced Trauma Life Support, or ATLS, algorithm pivots on one absolute boundary. We are strictly defining volume stability here. In the trauma bay, hemodynamic instability is defined as a systolic blood pressure under 90 millimeters of mercury that is completely unresponsive to an initial rapid blood or fluid bolus. This is it. This is your physiological line in the sand where intravascular depletion hits a critical threshold.
And this creates a brilliant high-contrast pathway. For an unstable patient, the CT scanner is literally a fatal decoy. You just don't have the time. If they're unstable, a bedside fast scan is your immediate move. Positive for free fluid? Boom, emergent exploratory laparotomy. You need rapid surgical control. Now, if and only if they are stable, the fast scan gets bypassed or supplemented by a contrast-enhanced CT scan to map the anatomy and plan a non-operative angiographic embolization.
Now, even in seemingly minor blunt trauma, visual markers have to drive your clinical suspicion. Take the classic seatbelt sign, for instance. Seeing that distinct bruising right across the abdomen is a massive red flag. It must immediately elevate your suspicion for an underlying hollow viscous injury or solid organ laceration, which dictates careful serial observation at the bare minimum.
Let's put this into practice with a high-level scenario. Picture this. You've got a post-motor vehicle collision patient. They had a transient response to fluids. Their BP is hanging around 84/50, and the fast scan is positive for free fluid. So, what's your immediate operative priority?
The choice architecture here is absolutely rigid. Unstable plus a positive fast equals an immediate exploratory laparotomy. You completely bypass a diagnostic peritoneal lavage, or DPL, because the fast has already confirmed the free fluid. Delaying surgical control for more diagnostics when the patient is in this decompensated state, that's a critical error.
Moving right along to Module 2, penetrating trauma triage and immediate operative indicators. Let's classify penetrating mechanical violations and establish that absolute hard sign boundary.
These absolute hard signs are completely unforgiving. Hemodynamic instability, peritonitis on a physical exam, evisceration of abdominal contents, or visible blood via a digital rectal exam or NG tube. If you see any of these, conservative observation and local wound exploration are entirely off the table. You're going straight to the OR.
Now, consider the actual depth and mechanism of the tract. Sure, a stab wound just violating the anterior rectus fascia might undergo local exploration if the patient is perfectly stable, but add any coexisting hemodynamic instability and the math instantly changes. And gunshots? A gunshot with a transperitoneal trajectory automatically mandates exploration. You just can't risk missing those severe, high-velocity occult visceral injuries.
Here's another diagnostic fork to chew on. A patient comes in with a left upper quadrant stab wound. They are completely alert and their vitals are perfectly stable. But gentle palpation elicits involuntary guarding and rebound tenderness. What's your definitive next step?
The singular variable altering this entire pathway is the peritonitis parameter. Stable vitals combined with peritonitis dictates an immediate exploratory laparotomy. The peritoneal signs, that guarding and rebound tenderness, they trump stable hemodynamics every single time. No serial CT, no local exploration, just straight to surgery.
Let's shift gears from the chaos of the trauma bay to the tightly controlled environment of the ICU. Module 3, Postoperative Fever Chronology and Infectious Mimics. We're mapping complication timelines using tight physiologic tracking.
You might be familiar with the classic 5 Ws framework. It's an elegant way to map day-specific differential vectors for post-op fever. Days 1 to 2, we're thinking wind, for atelectasis. Day 3 is water, UTIs, usually from indwelling catheters. Day 5 is walking, looking out for DVTs or PEs. Day 7 is wound, for surgical site infections. And by day 10+, we're looking at wonder drugs, or deep intra-abdominal abscesses.
Let's test this chronology out in the real world.
You've got a patient on post-op day 8 following a standard baseline appendectomy. Suddenly, they spike a new fever of 102.1 Fahrenheit and have focal lower quadrant pain. What strict imaging protocol do you have to follow here?
The choice architecture here actively challenges you to avoid blind, empiric antibiotic escalations. A new fever popping up between days 8 and 12 accompanied by leukocytosis absolutely mandates a CT scan with contrast. You are hunting for a pocketed, deep abscess that's going to need image-guided percutaneous drainage, not just a medication tweak. And of course, you have to watch out for the atypical vectors. Say you have a patient on total parenteral nutrition, or TPN, through a central line, and they get a sudden fever and leukocytosis. Your immediate reflex? Draw blood cultures straight from that catheter site. You absolutely have to rule out a central line-associated bloodstream infection, a CLABSI, before doing anything else.
All right, bringing it all together with Module 4, Clinical Reconciliation and Trot Variants. We're systematically cataloging easily missed surgical parameters. This is where peer-level clinical reconciliation separates a good outcome from a tragic one. Pay very close attention to these fatal workflow disruptions. Sending an unstable patient to the CT scanner, massive error. Misinterpreting day 1 post-op atelectasis as a bacterial pneumonia and hitting them with broad-spectrum antibiotics, another huge mistake. You also literally cannot afford to miss early abdominal compartment syndrome, indicated by elevated bladder pressures in heavily resuscitated patients. Oh, and performing blind wound explorations on high-velocity gunshot wounds displaying clear fascial violation, absolutely fraught. Now, imagine an ambiguous brunt trauma case causing severe epigastric pain radiating right to the back. If you isolate an elevated serum lipase or amylase here, it forces a brilliant diagnostic pivot. You must transition to non-operative, supportive management for traumatic pancreatitis. It completely keeps you out of an unnecessary and potentially harmful operation.
On the flip side, some radiographic findings leave zero room for debate. Spotting radiolucent free air under the diaphragm on an upright chest X-ray, that is an absolute radiographic threshold. It means you've got a perforated viscus, and it instantly triggers the need for emergent surgical control via laparotomy.
So this brings us to a final integrative scenario. You're faced with severe, ambiguous blunt trauma, fluctuating postoperative vitals, a rigid abdomen, a dropping hematocrit, and rising PT/PTT times indicating acute coagulopathy. How do you systematically balance these competing diagnostic and operative priorities as your patient is rapidly decompensating? When you systematically balance that raw hemodynamic data, it shows a patient sliding into disseminated intravascular coagulation, or DIC. Massive resuscitation driving DIC requires a swift damage control laparotomy. And here's the kicker. If you have a compromised bowel, spilling succus entericus into the abdomen, you have to utilize delayed primary closure. Trying to close that skin immediately over a contaminated field is just a recipe for a catastrophic wound infection. Ultimately, mastering these granular physiologic boundaries is absolutely crucial. It ensures that when those subtle variables shift in real time, your clinical management pathway is already decisively mapped out. So, I'll leave you with this thought. The next time you step into the organized chaos of the trauma bay, what exact physiologic variable will dictate your definitive line between conservative observation and immediate surgical intervention? Keep that question at the very forefront of your practice.